My presentation is a lot to do with Uganda, the experience in Uganda, but I will attempt to give, in the interest of those who may not know what fast track is, maybe just verbally explain what fast track is about. Today is 29th, and I think about this time in 2014, 30th, yeah, about the 1st of December in 2014 in Paris, France. Leaders got together, urban leaders, and they signed what they call the Paris Declaration that launched the campaign on fast tracking the elimination of HIV and AIDS in urban areas. So that's what they call fast tracking. The targets for fast tracking are the same as the 1990 that we have always talked about. I work for the Alliance of Mayors Initiative on Health and HIV in Africa. We call it the AMICAL in short. I work for the Uganda chapter. I don't know if there are countries in Africa here who have similar alliances, but I know that we link with the similar alliances in Botswana, in Zambia, in Zimbabwe, I think Zimbabwe, South Africa launched recently, and Malawi. The alliance was launched far back in 1997 when UNAIDS and UNDP invited leaders from urban areas, mainly mayors, into an ICASA conference, the conference that's going to happen soon here. And in that conference, the trends that in most of the presentations indicated that HIV/AIDS was uniquely affecting urban areas. So the leaders came out as political leaders and did a declaration, which we call the Abidjan Declaration, to find solutions to addressing those unique challenges of urban areas, especially regarding HIV and AIDS. So they set up an office in Windhoek, which coordinates our regional program in Africa. And in the year 2000, that's when mayors in Uganda also got together and formed this chapter, the Alliance of Mayors, Uganda chapter. We are now also members of the Global Alliance of Mayors and Leaders from Africa and of African Descent, GAMAD. And it's also doing a lot of work on this. So we actually operate as a non-government entity operating within the local governments, under the leadership of the mayors and the town clerks and the structure going down to the local level. L in AMICAL is at the local level. So we target the lowest person in the urban areas. So when you look at the profile of urban areas in Uganda, urbanization in Uganda, we say about 20% of Uganda's population live in urban areas. The growth rate for the country, population growth rate is about 3%, but for the urban areas, it's about 5.7%. And we have a population of about 2 million in our city alone, which covers about 40% of the total urban population. So the city itself is a key population spot. Kampala actually holds about the second position in the population growth rates in East Africa region. Now we're talking about the region. And 60% of the populations we are talking about in urban areas actually live in the slum areas, in informal settlements. The people we popularly call the key populations. The sex workers, the men who have sex with men, and all those groups that we know. But most importantly, that most of these are young people, unemployed or unemployable, and at risk. Many times if they have incomes, then they have disposable incomes, small disposable incomes that constitute risk as well. So it's estimated that by 2050, about 50% of Uganda's population will actually be living in urban areas. Now this shows you why we need to really focus and think about fast-tracking the elimination of AIDS in urban areas. Uganda alone is really rapidly urbanizing. We have currently one city with 5 city divisions, but we expect to have about 10 cities by 2040. They have already gazetted about 41 municipalities. We have 123 municipal divisions. These are independent local government entities, and we have up to 423 town councils across the country. I think this story might be related to many African countries. Urbanization is very rapid, and it's real. When you look at the demographics, especially in terms of HIV and AIDS, I've followed the trends from 2006 survey through to 2018, our recent survey. Clearly, it indicates that HIV/AIDS is an urban epidemic. Prevalence is always high in urban areas. 6.5 10%. This is national, this is urban. 7.3, we are at 8.3. In 2017, 6, we are going down, urban we are at 7. When you look at 2018, the most recent survey says 6, and we still have 7.3 in urban areas. We find that actually about 15% of all the people on ART are in Kampala city alone. And most of the most affected new infections are largely in urban areas. Sex workers, percentage is about 30%, and the rest. So, and then women, mainly business women in Uganda, largely in urban areas, are the ones where we are recording most infections. So this really speaks to the need to emphasize and to focus on urban areas as unique areas of risk. So as regards fast track, we as Uganda adopted fast track since 2014 after the declaration, the Paris Declaration. So from that time, the mayors declared a campaign in Uganda. We called it the Mayor's Campaign. They codenamed it One More Time. Do something that can make a difference one more time. By 2014, we are following the MDGs, ending by 2015. And we said, what can we do that can make a difference? In July 2015, the mayors got together and committed to have these campaigns every year to address issues of HIV and AIDS. In 2016, there was a big conference in Accra, organized by GAMAD, and we met there as leaders, and there was another declaration on fast track with UNAIDS. And in July, when we got back, all mayors got together in Uganda, and they signed the declaration, the Paris Declaration, and launched fast track in Uganda. So in November 2016, the Alliance of Mayors in Uganda reviewed its strategic plan and integrated the fast track cities strategy within our strategic plan as the alliance. So, and later on, recently in 2017, I think, the president of Uganda relaunched, together with the Minister of Health and Michelle Sidibe, they launched the Presidential Fast Track campaign. By then, we had actually developed the Urban Fast Track framework. I was stretching from 2017 to 2020. So currently, urban areas in Uganda follow the fast track framework, specifically looking at the approach that can have unique interventions that address the urban issues. I like particularly to note here, quoting Michelle Sidibe, that the success and failure of the 1990 campaigns by 2020 and the elimination of AIDS as a public health threat by 2030 will largely depend on urban areas. That if we do not do something about urban areas, we may not actually succeed, because the urban areas are the epicenters of the spread of the epidemic. Many of the things that we do in urban areas, we don't do in the rural. Whereas the rural people move into urban areas with rural mentality, the risks are much higher when they come to the urban areas. So as the Alliance, we have designed our program to be a leadership-led program with the leaders at the center. The mayors, particularly the political leaders, working with the technical leaders, both administrative leaders, medical workers, health workers, but under the leadership of the mayors. We also want to focus on an integrated and sustainable programming. I think Dr. here made a presentation and said if we do not put SRH integration, we may not achieve. That's what we are thinking, but we go beyond that. So in terms of the leadership role, if there is no adequate coordination of our work, which is their mandate, mobilization of resources and populations, advocacy, oversight, and accountability, we may do all the things that we do as public health workers, but we may not achieve, because many times key populations don't come out unless they are given that environment, unless they are given that support. So in programming for HIV/AIDS, sexual reproductive health, water, sanitation, and hygiene, which is actually a lot linked to HIV, and then non-communicable diseases. I think you know now, maybe those who have been doing clinical research will say the close link between NCDs and HIV currently is growing very fast. So that's why we do an integrated programming. We think that if we develop that capacity to be more effective and sustainable, we can achieve better health outcomes for the urban areas. So what the leaders really do is that they commit over the period of time. Here they all came together and signed this and said, we are going to judge ourselves based on this declaration. They move out, mobilize communities. They come and test publicly and call on other people to come and test. They give the confidence to the communities to come out. They speak out. They have this tool, the microphone. The mayor will be invited to speak in church, at a funeral, at a wedding, all the time. But if they do not know what to say, they will speak the politics. But if they can speak a functional language of prevention, of how to break stigma and the rest, they will make a very big contribution. So they move out, they mobilize communities, they go on radios. In Uganda, we have over, I think, about 200 FM stations now. And the government requires that every station should provide airtime to government programs. These leaders have access to that airtime. But many times, they don't use it. So they go out in the communities at the lowest levels and engage. So currently, what are we doing around Fast Track? So as I said, it's about 5 years down the road. I can't say that Uganda has really gone very far because of a number of challenges. So recently, with support from USAID and through UNAIDS and IAPAC, IAPAC is the International Association of Providers of AIDS Care, we have got support recently to implement a project on Fast Track for about 2 years. It's part of what UNAIDS is supporting and IAPAC in 15 high-burden countries. So Kampala has been selected as one of the cities. We want to see how this project can contribute towards achieving the targets by 2020 and by 2030. So as the Alliance of Mayors, Amical is the implementing partner on this project. And we are now making efforts to roll out this project aimed at strengthening advocacy and social mobilization in Kampala, mainly reaching those communities which are in urban areas but hard to reach. And then improvement of data collection. There is a global dashboard that is being established to capture the achievements that we are having, acceleration of service delivery, and then capacity development. So in terms of the achievements so far, when the campaigns have been done over time, there is time when we did a 1-week campaign across the country, and we saw that over 535 local leaders got sensitized within that period of time. And particularly in Kampala, we got about 150 leaders involved. 9 urban authorities reported to have conducted actual campaigns across the country. We had about 11,000 individuals reached with different services, mainly in prevention. We developed and adopted urban tailored fast track framework like I have shared earlier on. We face a lot of challenges. I think you'll agree with me that many times we think that urban areas are endowed, they have resources, they have human resources, their facilities are there, but the reality is that they are not. We are leaving them behind. Urban populations actually being left behind. We do not prioritize them. There is this argument that we need to focus on rural areas. That, for example, in Uganda, that 80% of the population live in rural areas. 20 in urban areas. But if you lose the Pareto principle, you find the challenges in AIDS and public health, almost 80% of the challenges are urban related. So I think that's one of the challenges that we have that we need to address. The other issue is the issue of statistics. Our census indicates, and our census is done at night. Night census indicates that it will tell us 20% of the population is in urban areas. The reality is that urban areas are flooded with people every day during the day. All of us work during the day, we stay in the town, we just go home to sleep. So in terms of planning for health services, in terms of the populations we deal with as urban areas, we are dealing with big populations. I said Kampala is 2 million, but day population for Kampala is sometimes over 4 million. And yet when we are planning, we plan with the statistics. I think the statistics need to be improved. There is also inadequate urban data to inform programming. I think we find the statistics abroad are general, and we do not have statistics that focus on urban that can help in this programming. Human rights and legal issues, especially relating to key populations. 2 minutes. Okay, I'm at the end. So the populations that we are talking about, key populations, outlawed populations, sex workers, those we're talking about are actually in urban areas. And the law does not give an enabling environment. That's why we have to work with the leaders who can make bylaws that can support them. Material, human, and financial resource constraints are also impediments to implementation. So we have learned over time that local resource mobilization is possible if we engage especially the private sector, the corporate companies. Integration approach is very important. If we are to succeed, have sustainable success in managing HIV. Leadership and engagement in mobilization of communities is very important. And indeed, the success or failure of the elimination of the epidemic will largely depend on urban areas. We have a video